Shalom. It's a pleasure to be here. So this talk will go over an overview of low-carb nutrition and how we can use it as a tool to treat and prevent chronic disease. We'll look at the mechanisms and the root causes. We'll look at heart disease, and we'll end with some clinical and practical approaches. So disclosures, I have no relationship to the pharma industry. I have no relationship to the food industry. I'm an author with Ivor Cummins of a book. I run a medical practice. And I think also I mentioned I do run low-carb conferences. And most importantly, my nutritional bias is low-carb, and I think that's important for speakers to reveal their nutritional bias. So some sobering statistics, and these are the big three, and that includes obesity, diabetes, and heart disease. And these are statistics, of course, from the US. National obesity rates approaching 40%. 70% of Americans are either overweight or obese. It's estimated, and it's an underestimate if you ask me, that 2/3 or more of the current US population are either insulin resistant, pre-diabetic, or diabetic. The American Heart Association estimates by the year 2035 that nearly half of the US population will have some form of heart disease. Now, if we could find an approach to treat these big three, I would be out of a job. But that's not going to happen anytime soon. But certainly if we could find a unifying theory or a root cause to address all these conditions, we'd be heading in the right direction, and that's what I'd like to discuss with you today. So diving right into the mechanisms and the root cause, this brings us to the metabolic syndrome. And the term was really coined by the late Dr. Jeffry Gerber. He referred to it first as Syndrome X back in 1988 during his signature Banting lecture. Now, you may be familiar with the name Banting, but we're referring to actually discoverer of insulin, okay? That is one of the Bantings that we're referring to, but not to be confused with this dead Banting right here. This is William Banting, and I had the privilege of meeting his spirit in Kensington, London a few years ago. And William Banting was an undertaker, actually, and his claim to fame was the Banting diet. So not to confuse the two. But back to the metabolic syndrome. And we refer to it as this deadly insulin resistance syndrome. And there are criteria that Raven created, and they include glucose intolerance, hyperinsulinemia or high insulin, or what we refer to as atherogenic dyslipidemia, where you have a low HDL, a high triglyceride, increased small particles, and we refer to this as ratios or the quality of the cholesterol. And you can see that LDL cholesterol is not a criteria here. And what you'll find out is that looking at the quality of the cholesterol is really just an indirect way of measuring insulin resistance. How about that? So the other criteria include elevated blood pressure, abdominal obesity. And what was important about this syndrome, if you had 3 or 4 of the criteria, your risk of developing type 2 diabetes, atherosclerosis, coronary heart disease goes way up. And now what we understand is that the metabolic syndrome seems to be associated with many of the chronic diseases that we treat today in modern society. Now, when I first learned about this some 25 years ago, this made so much sense to me because it really did define a root cause. What also made sense is to define that a low-carb diet would be the best approach. But as you see, diet wasn't really the discussion back then. It was more about the method, and we'll explain that. So then, a little bit before Raven, we have Dr. Joseph Kraft, who was very much interested in insulin metabolism as an early finding of prediabetes and diabetes in the metabolic syndrome. And he referred to it as diabetes in situ. And Ivor Cummins and myself had an opportunity to meet and interview with him a few years back when he passed away at the tender age of 96, I believe. And so what Dr. Kraft did during his career, his research was to analyze almost 16,000 patients, and he performed what's called an insulin assay. So he gave them a challenge of glucose, and then he measured glucose, and he also measured insulin over a 5-hour period of time. And let me show you what he found. So this is a normal pattern, or euinsulinemia, where you can see the insulin doesn't rise much above 60 microunits. And now we can superimpose these abnormal patterns of hyperinsulinemia, and you can see how high the insulin goes. Now, Catherine Crofts in New Zealand, for her PhD, reanalyzed the data, and she came up with a very simple clinical method, and that is to just measure the 2-hour insulin. And if your 2-hour insulin is less than 30, you're normal. If it's over 40, you have a problem. And this is what we do in our office each and every day. But thanks to the work of Dr. Kraft and also Dr. Reven, we now understand the natural history of type 2 diabetes. And so here's a timeline, and you can see at 0 years, you have your diagnosis of type 2 diabetes. And that one, unfortunately or not, is very easy to determine. Even a blind dog could figure this one out. So you have a fasting glucose over 126, you have a 2-hour glucose over 200, you have a hemoglobin A1C over 6.5. You're not really helping the patients by the time you diagnose this. But let's look what happens 20 years back. Well, Dr. Kraft realized 20 years back, you're hyperinsulinemic. If you chose to measure it. Most doctors don't even know about the work of Dr. Kraft. And then 15 years back, you develop insulin resistance. Now we can measure this more on a cellular level with a glucose clamp or a HOMA-IR. And then 10 years back, you develop IGT, where your 2-hour glucose would rise to 140 if you chose to measure that. And then in this depiction, say 5 years back, before the diagnosis, cardiovascular disease sets in. We make an argument that if you do the right measurements, you might even detect cardiovascular problems early on. But what you can see is that there's a problem going on for quite some time. People are sick, they don't realize they have a problem, and even the healthcare professional doesn't know what's going on. And so by the time you're diabetic, you're a mess. And so the point is, you have to have an early level of suspicion and to think about metabolic disease and do the right measurements early on. And that's what we want to teach healthcare professionals. So let's talk about the elephant in the room when it comes to metabolic syndrome. The elephant is nutrition. More specifically, low-carb nutrition. Now again, Reven and Kraft were both interested in their methods. Dr. Reven was an endocrinologist. Dr. Kraft was a pathologist. What did they know about nutrition? So they just went along with standard guidelines. It was later in their careers that they actually did realize the benefit of low carb. So what I'd like to do is compare standard approaches to diet with low carb nutrition. So let's do that for a couple minutes. So, standard diet, there's many names for it. And just to point out the fallacy, this is what I like to call it: the perfectly balanced, healthy diet. There you go. It's mathematically precise. A third of the calories rather, come from each macronutrient. It's mathematics, it must be correct. And so the conventions there are that, well, all calories are alike. The food quality is really unimportant because it's just about the qualities. This comes from, of course, the first law of thermodynamics, that in a closed system, you don't gain or lose energy. And your health and weight seem to be simply determined by this positive or negative energy balance. And it seems to me that the law of physics seems to take precedence over the law of physiology. That just doesn't seem right. And so calories in, calories out. We figured this out from the combustion chamber. I know Gary mentioned this, where you put organic material into this closed chamber, you ignite it, and you measure a rise in temperature, and you can see that organic material gives off different calories, different energy. And this again demonstrates calories in equals calories out. Is that how the body works? That's part of it, but there's much more to it. So some more conventions. With this perfectly balanced diet, they're telling us to reduce fat and to reduce saturated fat. Well, why do we want to do that? Number one, for weight loss. Since fat is caloric dense compared to protein and carbohydrate, if you want to have a negative energy balance, you just simply eat less fat, less calories. Convention number one. Convention number two that ties in rather nicely. If you reduce saturated fat, it's going to reduce your risk of cardiovascular disease. And Zoe just talked to us a little bit about that. And what's important to understand, it's all based on this fact that food substances, specifically fat, clogs your arteries. And we're really dealing with an inflammatory disease. It's a whole different way to think about it. And what do we do to address these conditions? Well, we replace the saturated fat with carbs and industrial seed oils, canola, corn, and soy. And now what we understand is that's actually a terrible combination for health. Although that's a powerful message that we need to teach others. The blame game is another issue. And it's a shame. We are so used to going to the doctor and they make us feel guilty because we're gluttons and sloths and we have no self-control. Well, that's wrong. We want to partner with our patients. And again, the emphasis is on calories rather than hormones. And they're both very important. And what do we get over 50 years? We've served up obesity, diabetes, and heart disease. So we need a better solution. We need to think about this differently. And the idea that all calories are not alike in terms of how the body processes the energy. So how do we know this? So again, we talked about the combustion chamber. Well, again, a long time ago, the researchers and the scientists came up with the metabolic chamber. And in this situation, we're measuring cellular respiration, quite different than combustion. And what they did is they put animals or humans into the chamber and they fed them or they didn't feed them and they exercised them and they started to measure things such as temperature, CO2 oxygen, VO2 max, aerobic threshold, oxidative potential. And lo and behold, they realized that the energy is processed differently depending on the situation. Now guess what? Calories in still equals calories out. But that's not the interesting part. What's interesting is how the energy is processed. So let's dive into that a little bit further. And so rather than call this calories in and calories out, I like to refer to it as energy in and energy out. And so again, the body processes the energy. It can partition the energy, meaning it can decide whether it's going to use the available energy right away that we consume, or are we going to store that energy? It also can decide whether stored energy can be used or not. And then, of course, we have the energy out. What's the body going to do with the energy? And in this scenario, think about the fact that it actually takes energy to process the energy and all the metabolic processes that go on. Another important pathway is feedback. Very common in biologic systems, and the system itself is self-regulating. And two examples of this, of course, are satiety and all the hormones that we have to keep in mind. So again, it's the processing of the energy that's important to us. Some more detail, I think it's fair to say, yeah, metabolism is quite complex. We should pay attention to that. There's many hormones and biochemical pathways that we have to consider. And insulin, again, is this anabolic. Anabolic refers to a hormone that stores energy versus catabolic, where energy is being released from the stores. And it is the fat storage hormone. There's lots of other hormones to consider, but insulin also regulates energy. We call that energy homeostasis. So it's important to think about insulin in this system. And then think about what happens when metabolic disease sets in to all these pathways. We see hormonal dysregulation and energy overload, and it's important. So that's almost saying hormones and calories. Again, there's stuff going on at the same time. They're not independent of each other, and we need to consider that. And in terms of feedback, Carbs and easily digested processed food drives appetite. Everybody across the board generally agrees with that. And so how do we address this? And this is where the low-carb, high-fat diet comes in. And so I have a different pie chart, right? And so this is a typical low-carb, high-fat ketogenic diet. And I believe that this should be the default diet for type 2 diabetics. And I could use any pie chart here other than the perfectly balanced, just to make the point that the macronutrients are processed differently. And here we have 70% of calories coming from caloric dense fat and saturated fat, 20% protein, 10% carbohydrate. And the conventions here, the macronutrients again are processed differently. Carbohydrates are fattening and inflammatory. Why so? Because carbs raise insulin significantly versus fat and protein. And again, I learned this back in medical school in the 1980s. But what I didn't learn, nor did they teach us, is how to apply that to nutrition. It's crazy. And therefore, if carbs drive insulin, if you reduce carbs, it's going to address insulin resistance. It's also going to control appetite as we're regulating blood sugar. We also have to consider that saturated by itself is not the CVD villain. And I'll say this over and over again. The heart disease is not a condition of something clogging the arteries. It is an inflammatory disease like everything else. And we have to look at the factors of what damage is the blood vessel. And it turns out that these industrial seed oils, the canola, corn, and soybean oil, are actually very unstable in the blood. Although if you replace saturated fat with the seed oils, it lowers LDL cholesterol. But what we realize now is that it drives inflammation. And again, this should be the approach to reverse metabolic disease and how we treat obesity, diabetes, and heart disease, the big three. So let's talk about insulin resistance in a little more detail. And again, it represents hormonal dysregulation. And insulin normally regulates blood glucose, but more importantly, it maintains this energy homeostasis. And the best way to really talk about insulin resistance is to look at this insulin resistance cycle. So if you start on the upper left, we eat food. Under a normal situation, if we tend to eat too much food, the body has the ability to store the food as glycogen and as fat. As time goes on, we might eat a little bit too much, and under a normal state, the body will still store the energy as adipose tissue, as fat. We keep eating, we're getting larger and larger at this point, and the adipose tissue, both subcutaneous and even the visceral fat, at some point says, wait a minute, we're full. We don't want any more energy. So we're going to become insulin resistant. And we're telling the system, nope, we don't need more energy. But there's a problem. So we have the pancreas and we have the liver. And they're saying, wait, we have all this energy. We need to do something with the energy. So what do? They try to fight against the insulin resistance, and we see more insulin getting pumped out to force the energy into the fat cells. And this goes on and on. The fat cells become dysfunctional. They don't want any more energy. It's trickling in. Insulin levels are high. And guess what? The fat cells can't even release the energy because of the high insulin levels. We see insulin resistance throughout the body, both centrally and peripherally. And we see insulin resistance. It ultimately drives hunger and appetite. So what do? We eat more. And the insulin resistance cycle goes on and on. And the two big problems is that we're overweight, we have adiposity, the energy is stored in the fat cells, we can't tap into it, we don't know what to do with it. And we're also driving appetite. Now there's many hormones that involve appetite and satiety. We don't have time to get into that, but consider insulin and its role here. So another way to think of insulin resistance is that it's metabolic mayhem. So we have another Banting lecture in 2018, just last year. And Jerry Shulman, who I had an opportunity to speak with, says that the problem with metabolic syndrome is energy imbalance, which leads to ectopic lipid and insulin-responsive organs, including muscle, liver, fat, which in turn leads to inhibition of insulin signaling. And so this even starts at a cellular level, where the cells can't process the energy. And just to summarize what Jerry was saying, there's just fat everywhere, and it's causing this problem with insulin signaling. All the way down to the cellular level, the mitochondria can't process energy, and again, we see all the organs start to have problems with processing energy, including the muscle, the liver, the adipose tissue. And ultimately, we see inflammation and oxidative stress set in, including reactive oxygen species, free radicals, and advanced glycation end products. And then it goes further downstream. We see inflammation in the blood vessels. We see high insulin levels, high glucose levels, and an inflammatory state. Fat is circulating in the blood as free fatty acids, and it ultimately attacks the blood vessel and every organ in the body, and it's metabolic mayhem. If we had more time, we could get into the detail, but this is just an overview. So how do we treat it? Low carb to the rescue. So this is a picture of a dam, and it represents the adipose tissue, where the energy is trickling in and it can't get out because of the high insulin level. So we treat it with a low-carb diet. We lower insulin levels, the floodgates open up, and insulin and energy, fat is oxidized, and it becomes readily available. We lose weight, energy comes out, appetite is controlled, and when you understand the physiology, there's a metabolic advantage for diabetics. And this high-calorie diet seems to defy thermodynamics, but really it isn't. You're just not accounting for the energy properly. And eating less, as you may know, is just spontaneous because of the metabolic advantage. There's a psychological advantage because we're focusing on satiety rather than deprivation. And so in this scenario, maybe calories don't matter. But consider this. You have a diabetic that needs to lose a lot of weight. They go on a low-carb, high-fat diet. They have success. They lose weight. There's less of them. And I tell you, if they continue to eat the same amount of food compared to when they started, they're going to hit plateau and the weight goes up. So another way to say that is that the quantity and the calories do matter. And so we have the two camps of thought, right? We have the calorie camp, the seco people, and we have the endocrine camp on the other side, the hormone people. And what I submit is that they come together in perfect harmony, and we form the school of food, energy, and metabolism. And the best part, this new school is bipartisan, and we need more of that. So let's move on to heart disease. Bottom line, we're dealing with a metabolic disease. Stroke and heart attack. It's damage to the lipoprotein, cholesterol, and the blood vessel wall. It has nothing to do with the fat-clogging arteries, or the fat-clogging macronutrient. It is an inflammatory disease. The blood vessel is getting damaged. And so if you address insulin resistance, and again, the cholesterol quality, which is a proxy to insulin resistance, these are the measurements that you want to be looking at. And that's how you predict your risk. So I hope that I've somewhat convinced you that it's well established in the literature that there's a strong relationship between diabetes and heart disease. But when it comes to clinical medicine, even today, there's a disconnect. And I see this all the time. So we have patients that come in that are diabetic and they don't know that they have heart disease. And we have heart patients that don't know that they're diabetic. And then even worse, their clinicians and their doctors are clueless. So you might ask, why is there the disconnect? Well, welcome to the Framingham Distraction. Yes, that's Framingham, Massachusetts, where back in the 1940s, they tracked patients for decades, or individuals, to see which ones had heart attacks and which ones didn't. And then they found these factors that seemed to be associated with events, and they called them risk factors. That's where the term came from. And we know them today, of course, as the bad cholesterol, smoking, high blood pressure, and yes, diabetes. And since the original Framingham work, they've now come up with guidelines, tools, and risk calculators, all with a central theme: to lower the bad cholesterol. And therein lies the problem. It doesn't properly address diabetes, doesn't measure for glucose properly, it doesn't measure insulin, it doesn't measure for metabolic syndrome. So the argument is this approach misses the mark. But there's always a but. I'm happy to say in 2018, the guidelines are getting better. David Unwin agrees with me. And they're getting better because finally, in the cholesterol guidelines, they're including metabolic syndrome. Now they call it a risk enhancer. So it kind of is subordinate to bad cholesterol, where we think it should be on the top, but it's a step forward. And then also they've now included heart calcium scores. So it's not really as a screening tool, but it gives the practitioner a decision tree in terms of what to do with middle risk individuals. Now it is whether or not you give them medication, but we'll talk about that in a minute. How should you properly measure for cardiovascular disease as it relates to metabolic syndrome and atherogenic dyslipidemia? So this is a complicated slide, and it's courtesy of Steve Finney, Jeff Volek, and the Tim Noakes Foundation. And on the top of this chart, well, first of all, this compares low-fat to low-carb diets. So it's kind of a dietary approach. And on the top of the chart are the numbers that measure atherogenic dyslipidemia, and the bottom numbers measure metabolic syndrome. And the yellow bars that move far to the right are the low-carb diets. And so you can see all the metabolic markers drop and improve in a significant way, such as ApoB over ApoA1, triglyceride over HDL. There is one yellow bar on the left where HDL goes up. On the bottom, you can see the metabolic markers, the HOMA, the insulin, the glucose, abdominal fat. And so in each situation, you can see that a low-carb diet improves the metabolic markers compared to a low-fat diet. Now, this is associational data, but we think the associations here are rather strong. And the point of this slide is that these are the markers that we should really be looking at when it comes to measuring cardiovascular risk. And the bottom line for my dear healthcare professionals is that we should focus on metabolic disease and insulin resistance. And it's the damage to the blood vessel wall that we're really concerned about. And if you're addressing insulin resistance, LDL-C, LDL-P, the particle count, really becomes less of an issue. Again, focus on atherogenic dyslipidemia and metabolic disease. And if you focus only on LDL, so we have our blinders on and this very narrow approach to looking at cardiovascular risk, you're missing many. And we like to say if it weren't for LDL, everybody would be on a low-carb diet. So more importantly, this is about a diet and lifestyle approach. It's not pumping people full of medication. I love that part. So cardiovascular imaging, we're almost finished here. If we had a tool where we could look inside and see the disease, we could really see a lot. It's an engineering stream. Well, we have such a tool. And this type of imaging, you can determine risk based on seeing the disease process itself. Now, one thing to understand is standard blood markers are associational, but they do provide us with information as to what the current state is. So they're important. Whereas when you look at the cardiovascular imaging, it provides us with historical data. So here's a CT scan of the heart, uses a little bit of radiation, and it takes pictures, and you get a 3D rendering, and the radiologist can measure the calcium, which is really plaque, in the blood vessel, and they add it up and you get a score. So the individual on the left, you can see the area in the green is the left anterior descending artery. That's the widowmaker. There's no calcium. That's a 0 score. On the right is an individual where the LAD is riddled with calcium and disease. So that person has a very high risk versus low risk. Calcium, again, is not a risk factor. It's a disease marker. It sees the disease process itself. And based on this, you can determine your score. And you can see with a 0 score, you have less than a 2% chance of having an event over 10 years versus a very high risk when your score is over 1,000. This data is 30 years long. And it's been done on hundreds of thousands of individuals. Again, the Heart Association in 2018 now include the calcium score in middle-risk people and basically say that if you have a high score, you need to think about medication, and we do have that discussion with our patients. But we also have the discussion that they should not underestimate the power of nutrition. And we can also track progress. So lastly, on the clinical assessment, must realize that it's not always insulin resistance. And here's the thing, you can gain fat without insulin early on, and we must not forget that. So we have insulin-sensitive individuals, the person on the upper left, the slim, healthy person, doesn't really have a problem. But on the right, we have insulin-sensitive overweight women especially. So they have a lot of subcutaneous fat, they're metabolically healthy. And if you put them on a low-carb, high-fat ketogenic diet, they might lose a little weight, but they're easily going to plateau and the weight's going to go up. And so with them, like everybody, we want to find tools and ways to control appetite. But ultimately, eating less is important. We're trying to bring that all together. And then, of course, we have the insulin-resistant individuals, of which represents 2/3 of the population, and they respond quite well to a low-carb, high-fat diet. On the left is the slim, what we refer to as thin on the outside, fat on the inside, Asian individuals, and then the classic type 2 with the big visceral fat belly. So we like to be simple with clinical evaluation. Early level of suspicion to think about metabolic syndrome. We can do anthropomorphic measurements, simple testing such as fasting glucose, HbA1c, standard lipids, but thinking about it differently. We can get nuanced testing such as insulin, HOMA-IR, C-peptide, HSCRP. We can do the 2-hour glucose with insulin, and I think that's a really important test, and the cardiovascular imaging. So treatment for a healthier life. This is what we love to discuss with our patient. This is kind of a summary. So we want to limit processed food, sugar, grain, the industrial seed oils, eat real food, control carbohydrate, prioritize protein, fill with fat. A little more protein, a little less fat long-term is a good thing. If it's working right, we're going to control appetite, but sometimes we need to mix it up a little bit. Again, the macronutrient mix will be different for the individual. Supplements, sleep, stress, sunlight, all important things to consider. Movement and activity. And if you're a healthcare provider, like we do, we provide education and support. We see patients back, educational materials, we have support group, all important. So just one last comment is that in talking to our friends here in town, apparently veganism and vegetarianism is very, very popular in Tel Aviv. And what I like to do personally is to find some common themes that we can agree upon. There's a lot there. So we finish where we started, and the point of the whole presentation is that we can use the right foods that can be powerful, like medicine. Now, I'm not the first guy to say it. The father of modern medicine, Hippocrates, said it thousands of years ago, and I think it's fair to say that we were not listening up until now. Thank you.